Hi, this is Dr. Nancy Tierney, and I'd like to welcome you to NU621, Advanced Pathophysiology, Week 2. This video will give you some basic information on Hemophilia A. And this will correspond to the readings that you may have accomplished so far in Week 2 for hematologic processes. The specific reference that this information has come from is here on your screen. You should download it, and then you can click on the web address, and this is the most current information that I could find on this topic, as there are changes and recommendations made for treating individuals with the different severities of hemophilia A. As you can see, hemophilia A is the most common X-linked recessive bleeding disorder. So since it is X-linked, it usually affects males. Females can be carriers, and so then can pass this on to their sons. You distinguish hemophilia A from hemophilia B by the fact that there is a normal factor IX activity level in hemophilia A. Just to refresh your memory, hemophilia A is a problem with factor VIII. Now, the only way that you can distinguish the two conditions is by doing a test for factor VIII binding assay. 25% of the cases that have hemophilia A have no family history identified. Talk a little bit about the classification and patient presentations of hemophilia A. There's mild, moderate, and severe levels of severity. The patient presentations differ a bit in the demographics as well as the bleeding and hemorrhaging that they present with. To review, mild hemophilia A is usually manifested later in life. It is usually associated with trauma and surgery, and it is occasionally spontaneous. Compare that to moderate severity hemophilia A, manifest by the age of 5, usually found in cases of trauma and surgery, which cause hemorrhaging. There is also spontaneous bleeding into the joints, or hemarthrosis. Of course, there is severe hemophilia A and severe hemorrhaging. This is diagnosed by the age of 2. There is frequent bleeding into the joints and muscles, and spontaneous hemorrhaging occurs from infancy. Look a little bit at the morbidity of hemophilia A. It's fairly specific. The most common cause of morbidity in patients with hemophilia A is hemarthrosis, which again is bleeding into the joints. This causes severe pain and varying degrees of immobility. When there is bleeding into the joint, or hemarthrosis, this causes synovial inflammation, and they form new blood vessels in the joints. And it's usually the ankles, knees, or elbows, or the hinge joints that are affected. This causes repetitive hemorrhaging and joint malformation. If they've got extra blood vessels in there, and there's irritation and swelling from the bleeding and the hemorrhaging into the joint, you're going to have more hemorrhaging and more malformation. The earlier that hemarthrosis manifests, the more problems the patient will have over their lifetime. And that seems to be intuitive. The sooner it starts, the more damage there's going to be. If you look at the article, there are some really good pictures and x-rays of hemarthrosis and the debilitating manifestations that it causes. With severe hemophilia A, the treatment recommended is routine prophylactic factor VIII infusions to prevent or suppress bleeding. This has been shown to minimize hemarthrosis and prevent joint damage. Treatment for mild or moderate hemophilia A is to infuse factors at the earliest signs of bleeding. There's no recommendation to do routine infusions of factors. If the patient experiences head trauma, the recommendation is to always treat it as an emergent situation, even in the absence of neurologic changes that you look for. There's a great table in the article that outlines the treatment for life-threatening hemorrhage as well as the routine therapy for chronic treatment. This most likely will not be done in your office, as the recommendation is for patients with hemophilia who require routine prophylactic factor infusion be sent to specialized centers throughout the country. But you will be evaluating these patients routinely, and you're probably going to be the first person they call if there's hemorrhaging. And so it's good that you familiarize yourself with the recommendations if you have these patients in your practice. As I mentioned, routine follow-up care should be at, there's over 150 government-funded centers in the United States. For those with mild disease, the assessments are recommended to be every 2 to 3 years at one of these centers. If they have severe or moderate hemophilia A, the recommendation is that these patients are seen at these specialized centers every 6 to 12 months. You will be involved in monitoring the progression or the appearance of any joint disease and transfusion-transmitted infections. So again, being familiar with the recommendations for management of these patients will be necessary. I want to thank you for your time. Please take a look at the reference that I included at the beginning. It really is very good, and there's some specific information about what factors are infused and when they're given if you're interested in this information. If you have any questions, please don't hesitate to email me through Blackboard or call me. Thank you for your time.